Where we picked up last time was with the knee and everything else. And so where we're going to start now is with the hip, thigh, and groin. And a couple things, I know we did it last time, but just to remind you guys, we went over the hip motions. Make sure that you're understanding all of the different hip motions. And we've talked about this before in the Friday class that was on the 13th. And if you don't understand the ranges of motion, it's going to be problematic. So make sure that you are looking at that stuff and kind of paying attention to it. And I think that this diagram does a pretty good job of explaining the different things. Remember too that I said if you're going to be doing hip internal and external rotation, I highly recommend that you do it with the knee flex like you can see in this picture, as opposed to doing it with the knee straight, so that way you can really tell what's going on. And in addition to that you are not focusing on the foot. Because if you go in, notice the foot's coming in, but the hip is actually going in what direction? What kind of direction is the hip moving in if you go into your foot in? Chat room. Hope I can see the chat room when I share my screen. No, did you click it off?
No, this is the chat.
Oh, okay. Good morning, Axel. So again, the question is, if I'm here and I'm rotating my hip and my foot comes to the inside, what motion? We're talking about going a rotation motion. What are we doing? Okay. Yeah, we're kind of like a 50-50 on internal and external rotation. So this is something that I don't want people to get confused about when we're doing it. So don't pay attention to the foot, pay attention to the hip. So if you are sitting, and everybody's probably sitting right now, if you pay attention to your femur and you rotate your foot in, what did your femur actually do? Did it rotate so it's facing in, or did it rotate so it's more out? And if you put your hand right in the dead center of your femur, you're gonna see that it kind of goes out, right? And so out would be external rotation, not internal. So the same thing, if we put our foot out, then what you're gonna see is your hip is actually going in. So don't get confused. The position of your foot doesn't actually matter at all. What matters is what your hip is actually doing. Same thing as I said, if you're going to be looking at rotation of the lower leg, again, do it with your knee flexed. And so that way you're seeing actually if it's rotating, you can't see my foot because the other table's in the way, but you can't see if it's coming in or out like this. Because if your leg's straight and I come in like this is actually hip internal rotation, not lower leg internal rotation. So for both of them, I recommend trying to have your knees bent when you're doing it, just to kind of keep it straight, but really focus on what it is exactly that you're doing. The rest of them are hopefully kind of common sense. We've talked before about all the rest of them. So then, click back on the box. When you click on the box. No, on the actual PowerPoint. Okay. So I made a couple new slides with extensors and all that kind of stuff, just to kind of show you the different types of muscles. So that way you can really be thinking about extensors, flexors, adductors, that kind of stuff. And hopefully this is helpful. Some of the other pictures, I know that the one that was in there wasn't super clear. And so it was kind of fuzzy and everything. My purpose of doing this is so that way you can actually see the muscles a little bit better and see the orientation of them. So understanding which ones are really going to move you into extension. The glutes, of course, are your major hip extender. That's your strongest hip extensor muscle. Your hamstrings are great and they're really important for it, but your glutes are much bigger and much stronger. So your glute max is your primary hip extensor. For the hip flexors, we have the iliopsoas, which is your iliacus, and your psoas major and minor together. And so those are your major hip flexors, but then notice we also have the sartorius and the rectus femoris. The rectus femoris being one of your 4 quad muscles, and it's the only one that actually extends across the hip. The other 3 quads only cross the knee. So the rectus femoris, because of that, because it's a biarticular muscle, actually is the one that gets hurt the most because it has 2 access points. So crossing 2 joints is actually harder on a muscle because it can have kind of 2 ways to get hurt instead of just one. And then with the sartorius, the thing to know about the sartorius is that it is the longest muscle of your body, which is kind of cool. It crosses your hip and it crosses your knee. And when we do the figure 4 kind of motion, that is actually what the sartorius does. All of those motions are sartorius motions. So it does hip flexion, a little bit of abduction, it does external rotation, and it flexes your hip. So the sartorius actually has multiple actions in it, and it's smaller as far as width muscle goes, but it's very long and it's very important in a lot of the activities and movements that we do during the day. And then we have lots of adductors. And notice that they're all on the inside. A lot of times we call them groin muscles, and they start from really small muscles, the pectineus and that kind of thing, all the way down to big muscles, namely the adductor magnus. And they extend all the way down. And then we also have hip abductors, so coming out. And the primary one is going to be your glute medius. And we'll talk about the glute medius in a little bit, but the glute minimus also helps with this, and a couple of your other smaller muscles also assist in that as well, okay? Then when we look at hip internal and external rotators, this is just another additional picture that can hopefully help you guys see what is involved in those. So again, internal hip rotators are going to be bringing your hip in, and external are going to be bringing your foot and your thigh out. And notice for the external hip rotators and the internal hip rotators, it's kind of interesting that your gluteus medius is actually on both. The slides aren't changing? Click on the slide.
Oh,
Now can you see it? Huh. Curious. What slide can you see? Oh, it's frozen on the title page. I've not been on the title page this whole time.
that's really good.
Hold on. All right. Now you guys can see the screen, yeah? Okay. I'm gonna try one more time. Maybe if I share this screen. Can people now see the PowerPoint? It should say hip movers continued. Okay. So let me see if I can do this then. I'm gonna back up a little bit so that way you guys can see what I was looking at. Everybody can see hip motions? Cool. All right, I'm going to see if I can do this. No, it's not going to, but, so this is hip motions. Can now you see hip movers? Okay, that is super weird. All right, sorry about that. Thanks for letting me know that you guys couldn't see what I was talking about. That's a bummer deal. So hip movers, this is the extensors, the hip flexors, and the adductors. And that's kind of what I was just talking about a second ago. And then these are the next hip movers. So internal hip rotation and external hip rotation. And again, notice that the gluteus medius is on both of these because of its actual location. And then for our external rotators, most of them, we call them the deep six. They're in your butt. They come off of your sacrum, either the anterior posterior portion of it, and then they come out and insert on your greater trochanter of your hip, and they help move it out. And by themselves, they're all really, really small muscles, but together they make up a pretty big muscle, and they help with moving of the hip quite well. So now we're going to move out of that stuff and we're going to go into some of the injuries. And I'm going to tell you right now, I'm not going to talk about all the injuries. I just wanted to talk about a couple of them that people get confused a lot, because I feel like in the narrative PowerPoint, I talk about a lot of stuff, and in the book, it goes over a lot of your injuries. So the injuries I'm going to talk about right now aren't the only ones that I think are important, but they are ones that I think people sometimes get confused. And so I want to make sure that you guys understand them. So just make sure that you understand that I'm only going to talk about a couple, that these aren't the only ones that you need to know. But with femoral stress fractures, as all stress fractures, and we talked about them in the foot, that they really are an overuse kind of thing. So you don't just all of a sudden, boom, get a stress fracture. It's something that's been developing over time, and the bone is slowly wearing or breaking down. And we talked several chapters ago, I think it was in chapter 10, about osteoclasts and osteoblasts. And the osteoclasts are what break stuff down, and the osteoblasts are what build bone up. And what happens often in stress fractures is that your osteoclasts just go crazy and they're just chugging through stuff and they're breaking the bone down because you are putting a ton of stress on it. And the osteoblasts can't keep up with the pace of the osteoclasts. And so you start seeing microfractures in the bone. And we talked before about how it kind of looks like your grandma's china, where you get those little cracks through it. Now, it is possible for those cracks to actually become bigger cracks and become full-fledged fractures. That doesn't mean that they are going to become full-fledged fractures, but that's certainly something that can happen. And the most common place for these to happen is in the femoral neck. And I'm going to use bones here. Because even though Leah's skinny, she's not so skinny that I can really show you this. So let me see if I can zoom it in a little bit better. When you're looking at bones, oh, I went the wrong way. When you're looking at bones, whoop, what we have is this circle thing right here. This is the acetabulum, okay? That is where the pelvis comes together. The pelvis, if we look at one side, this whole thing is a single innominate. So we have up here is does anybody know what this top bone is called? Hopefully, at least some people know what this top bone is called. Yeah, okay. So this whole thing is going to be called the ilium. This rounded part right here is going to be your iliac crest. This part right here, this bony part that's sticking out, see that? This is your ASIS. And that's an important location because we have several muscles and actually ligaments and tendons. Actually, the tendons attached are not the real muscles. But this is your ASIS right here. This is a super important point. And then underneath it, we have another protuberance. And this dude is called your AIIS. So anterior superior iliac spine, anterior inferior iliac spine. This is where several different types of muscles insert. Then what is your butt bone called that you sit on? What is this dude called? Okay, so this guy right here that I'm touching, this is actually your ischium. Your coccyx is actually your tailbone. It's part of your sacrum. So down here, this right here, this is your ischium. This is your butt bone. This is what you sit on. Your tailbone is your coccyx. Your coccyx is actually part of your spine. Your ischium is what's part of your pelvis. And then the last part, what are these front bones called that are part of your pelvis? Yep. Yeah, your pubis or your pubic bone. So if you put your ilium, your ischium, this guy right here, and your pubic bone together, all three of those on one side make a single innominate, okay? And so understanding that these all go together is important, and then they make your acetabulum, and it's almost like a three-way pie in there, where this in here is your acetabulum, where your femoral head fits into that. So just coming off of that is your femoral neck, this skinny part that sits right there. Notice you can see it all the way around. And the femoral neck is what brings your greater and lesser trochanter, so the main part of the femur, and then brings it into the head. And the head is what comes in and sits in this ball and socket joint here in the hip. This whole thing right here is a really important thing for you guys to understand, because a ton of injuries happen here. And this is also where a bunch of muscles and ligaments and again, everything else kind of attaches. So understanding how this hip joint comes together is something that I highly recommend people know and understand. One of the things that can happen is if you have a hip dislocation, which in your book and in the narrated PowerPoint, I talk about some things that can happen to children as well as to adults as well. But if you dislocate your hip, there's an artery that connects and it goes through the acetabulum actually into your pelvis that actually gives blood supply and nutrients to your femoral head. And if you dislocate your hip, what can happen is, not can happen, it does happen, it tears the artery that's in there and the vein. And so it makes it so that way you have zero blood supply. And if you don't have blood supply, what is that called? There's a injury that we've talked about that is problematic for people that don't have blood supply to an area, and then something happens. Do you guys remember what that was called? I'll give you a hint, it's 2 words. Avery's the only one brave enough to say it. Good job, Avery. It is avascular necrosis. So what happens is the cartilage and the head of the femur actually die when that happens. So that's why hip dislocations are such a big bad thing, and they often eventually, not immediately, but eventually lead to people having to have hip replacement surgery because their head will die and eventually it squares off. Instead of being nice and round like it's supposed to, it'll square off, and then it makes it so you have all kinds of problems in your head. Okay, so I wanted to make sure that I explained that, but the femoral neck, this narrow part right here, this, you can't do anything, say, I did the thing. But the femoral neck right here, this is where stress fractures most commonly happen. We can get regular fractures here too, but stress fractures, this is their most common site. All right, and it can be achy and go on for a long time and have all kinds of issues. Just understand that that's kind of something that we see and that can happen as we go through trying to treat people. The next thing is a positive Trendelenburg's test. And I'm going to go over it now so that way we're talking about it. But what you see is if you're going to test one of your patients, let me bring it down a little bit. Oh, wrong way, wrong way, wrong way. I'm still learning. Okay, so if Leah had potentially a right side femoral fracture, what I would do is, which side would I ask her to stand on first to do the test? If she has a right side, I think maybe she has a right side femoral fracture. Yeah, for sure. Absolutely. Good job. Left side for sure. So I'd say, okay, I want you to stand on your left side, put your hands kind of on your hips, and then I just want you to kind of stand like a stork. And so she would stand like a stork, and then what I would be doing is I would be looking at her hips and to see if there's any difference in how high they are. And if there's no problem, sorry, there's a screw on the floor. If there's no problem, then her hips would stay nice and level. But then I would say, okay, that's great. Now let's switch sides, and I want you to stand on your opposite side and see what happens. And so if she were to stand then on her right side, and she had one, what we would see is something called Trendelenburg, which would mean that her hip, her opposite side hip would drop, because what happens is the side that's hurt isn't strong enough, or it's too painful to make sure that she's using her gluteus medius to hold herself up. So if she was feeling good, then she would stand level. But if she has a potential hip fracture, well, not hip fracture, but a stress fracture, you would see the opposite side drop, sorry, when she goes into that position. So it's not the side that you're standing on that drops, it's the opposite side. It's your non-weight bearing side that you would see drop down. Antalgic gait, does everybody know what antalgic gait is? I talked about it in other classes. What is it? Because that's going to be an important term for you guys to know. I appreciate the honest answers. All right, so if people don't know, antalgic gait is walking or gait because of pain. And walking or gait. Limping while walking because of pain. So if she had a problem, that would mean that she would be trying to take the weight off of her right leg because it would hurt to be weight bearing on it. So antalgic gait means that you're limping and you're walking kind of funny, and it's because of pain. Yeah? I'm gonna assume everybody gets it. Okay, so then our next one is just this particular picture. Thanks, Charlie. And Axel. Okay, so if you look at this again, notice these show through and through fractures, but that's not really a stress fracture. Again, I wanted to make sure that it was clear that a stress fracture isn't a through and through fracture, but these are true fractures, but this is where they can occur. When we talk about femoral fractures, don't usually happen in kids. We see them a lot more in middle age. Typically, we're looking at big car accidents or falls from a height or something really major, or like taking a direct impact, like right in the middle of your femur. Sorry, you can't see what I'm doing because there's chairs and stuff in the way. But that's the kind of stuff that we're thinking about and we're looking at. So think big, big things are happening. A couple things I really want you to pay attention to for this are the positioning. When you have a femoral fracture, the leg or the hip is going to present an external rotation and abduction of the hip. So external rotation and abduction. Let me come out here. External rotation and abduction. Do you think, well, not do you think, it's obviously on the slide. You will have a shortened leg as well. Why do you think that the leg will appear shortened on the side with the fracture compared to the other side? Yeah. Yep. Yeah, that can happen, Katie. So what we're gonna see is if something's broken, if it's broken like that, think about how big and how strong all of your thigh muscles are. They're the biggest and strongest of your body. And anytime something happens, remember we talked about that our muscles around those things are going to try to protect it. So they're going to try to, oh, probably axle, I believe it. So they're going to contract down. And what happens is, especially if it's a displaced fracture, when that happens, the bony ends actually shift and they slide. So your leg can actually appear a lot shorter than the opposite side. And that's actually really dangerous for people. And you can even see it in the picture that's on your screen where it's broken, where it shifted and then it slid down. And it's really dangerous because think about that, all of the arteries, they're really deep and they're really close in there. And then those bone fragments or the ends can actually go through and slide and go through muscle, go through nerves, go through all kinds of things. So even if it's not an open fracture where it's coming out of the leg and the skin, you can actually have massive amounts of internal damage from having femur fractures. So always, always, always look for external rotation and abduction of the hip, and that the leg is going to be shorter on the affected side. Yeah. Oh, yeah. Even after he got it fixed, it's shorter? Man, that's rough. So notice that you see on the slide that there is that great big rod that's in there. That's something that we would look for. So when we're caring for these people, remember your muscles are really vascular. So you need to make sure that you're looking and you're treating for shock, which is keeping them warm, talking to them, trying to keep them conscious, elevating the legs. And you might not be able to elevate the injured leg, but you can at least elevate the other leg. You need to call 911 right away. And then this is a new acronym that I don't believe that we've talked about before, ORIF. You need to know this acronym. Are you, as the first responder, going to take them to surgery? Is that something you are going to do emergently? Yeah. No. Even if you were the person that rolled up on the injury, you're still not going to take them to surgery because you're not on duty. But they need to go to surgery. And ORIF stands for open reduction, internal fixation. Open reduction, internal fixation. And basically what that means is they're going to cut open your skin and they're going to line the bones back up, and then they're going to put a big rod in there or a screw or plates or something else. And for the purpose of a hip, they put a big rod, they put a drill, and they go through your intermedullary canal, and then that's what it looks like. And these, again, are some of the areas where you would see the types of fractures, either stress fractures or regular fractures that would occur in the human body, and at least in the femur anyway, okay? Conversely, we have a dislocated hip. And now the most common that we see are posteriorly dislocated, and they often occur in car accidents because when we're sitting, we're like this, and the dashboard comes back and hits our flexed knee, and we're sitting with a flexed hip, which is the perfect position for our femoral head to dislocate. So what it looks like is we're sitting here, and he's in this nice bent position, and then we have a direct impact coming through the knee, and it pushes this femoral head straight out the back. Okay, so it's going to be sitting back here, and again, their leg's going to look all kinds of weird, but notice that instead of that abducted, externally rotated, now we see a flexed hip that's adducted and internally rotated. So it's going to look more like this. It's going to be kind of crossing across because the femoral head is basically sitting in their butt. Okay? They need to go to the hospital. You will not be able to put it back in place with your own two hands because, again, remember, the gluteus maximus is so crazy strong, and all the other hip muscles are going to start contracting down, so you just need to stabilize them. Remember when we were doing all the spine boarding and everything, we said for femur fractures and for hip fractures, the best way for us to immobilize that is using what? What would we do? Woo! For mobilizations. Am I drawing? Somebody else drawing? How would you immobilize either a femur fracture or a hip fracture? Oh, people figured out they can draw on the screen. All right, you are exactly right, Meredith. A spine board. Remember we said that we need to use something that's going to go the whole way. If we use one of those vacuum splints, the problem with that is you can't actually immobilize the hip. And the only way to immobilize the hip is actually to put somebody on something that can immobilize their torso. So you would have to put them on a full spine board, or potentially you could even put them on a scoop stretcher. That would totally be okay as long as you could hold them in place. But those are a couple things to think about as you're doing it. But they would absolutely need to go for immediate care, and to come back from that can actually take quite a while. This is what it looks like. Notice how that femoral head is put way back in the butt, or it's backwards, and then how their leg is in. Is there a position that you can put them in to reduce pain? All. Axel, that's a really good question, and mostly no. Unfortunately, the one thing that might maybe help is to put something underneath their knee, because having their hip go straight is actually painful because their femur is basically back in their butt, not where it should be. So sometimes supporting their knee and supporting it in a little bit of flexion, so putting a pillow or a blanket or a hoodie or something underneath there can be helpful, instead of just making the gravity and the weight of their leg pull their knee and their hip into extension. But outside of that, that would be about it. But strapping them flat to a backboard where you would force their leg into extension, like the whole entire thing, would actually be painful for them. So you would want to splint them in the position that they're found in, and then try to support it as best you could, so that way they weren't experiencing additional pain just from it getting pulled into extension. Yeah, good question. Yeah. All right, special tests. If there's a fracture suspected, the following are done, which should make sense. So if you think that they broke their femoral neck or anywhere in their femur, you're not going to want to move their leg around. Don't move their leg around, just splint them and call 911. If you think that there's any chance that they have a femoral fracture, always, always, always make sure that you are calling 911, because they can bleed out because there's lots of really, really big arteries in there. So, Leah, please. These are tests that you would do if you don't think that they have. So notice it says begin an extension, the knee is passively flexed. When we're doing this, what position do you think that they're in when we're doing this test? Are they standing? Are they prone? Are they supine? Are they on their side? Yeah, absolutely. So supine. Good. So again, it says beginning an extension, the knee is passively flexed. So here we are in extension. Can I passively flex her knee from here? Is this possible? Kind of a trick question, a little bit of a trick question. If I ask her to slide to the edge of the table, and promise that I'm not gonna let her fall off, she can be an extension, and I can go like this, because it's still being passively flexed, right? So it depends on if she's on a table, or that I can do this, or on a bed, or if she's gonna have to lay on the ground. If she's gonna be laying on the ground, then I can't have her laying in supine, and I would have to make her lay prone to do this. But the point of doing this is to see, okay, can I do this? Is this allowing me, like, is there anything wrong in her quads or in her knee that is going to prevent this? Is there any kind of block that's going on in the back? Because again, we're just trying to see motion, and the further back I can go, the better it is for her. But hopefully it makes sense that that would happen. Then the next thing that we would do is active movement from flexion to extension. And again, I can have her stand to do this, or I can have her go just on her own. So actively, I would say, okay, I want you to try to bring your foot as high as you can in the air. Good, good, good. Oh, that's terrible hamstring flexibility. And then I can have her do the opposite and lay on her stomach and go the other way. Or if she's standing, I could just have her hold onto a table and say, bring your leg up as high as you can, and then bring your leg back or into extension as far as you can to be able to check that kind of thing, okay? And then muscle weakness against an isometric resistance. Isometric, remember, means that we're not moving. So what I would do is I would maybe say, okay, I want you to hold your leg right here and don't let me push you down. Okay, so I would say I'm going to push your leg down, hold, relax, and see if she can do that. So that would be isometric. And then I can do the opposite and say, okay, I want you to not pull me up. And so now she has to use her hip extensors to do that. I can also bring her down into extension a little bit and do the same thing and say, don't let me pull you up. So she again has to use them in the back side. So I can assess different ranges of motion. Remember when we talked about resisted range of motion and going through certain static points? That is assessing the isometric stuff. But if she can't do those things, then we're probably thinking that she has some kind of nerve injury. So it could be something along the lines of a sciatica, or it could be something coming out of her back. And we'll talk later in chapter 25, I think, about back stuff and nerve injuries and disc injuries. But those are some things to think about that as we're going through stuff, that could be potential things that could be going wrong. And again, you would flip them on their stomach and on their back to make this a little bit better, but the table's hard, and for sake of time, I'm not going to have her do that. All right, functional evaluation, range of motion. We've talked about all the ranges of motion and strength tests. When we do strength tests, I would typically do things with her knee flexed and her knee extended, because I need to see if the rectus femoris and the hip flexors are the problem, or if it's the quads that are the problem on the front side. On the back side, your hamstrings are, for the purposes of this class, all biarticular muscles, meaning that they cross your hip because they insert on your ischium, and then they also cross your knee. And you know that because we talked about how they flex your knee, but how they also help extend your hip. So they're biarticular muscles. Of the quads, remember I said that only one of the quads is a biarticular muscle. Do you guys remember which one it was? All right. It's okay, Will. Yeah, your rectus femoris. The rectus femoris is the great big long one. It comes from your hip, so off your AIIS all the way down and becomes your conjoined quad tendon. That is something to pay attention to. Another thing is if you fracture your patella across the middle where it actually would sever that quad tendon, it makes it impossible for somebody to actively extend their knee, but I can still passively extend it because that means I'm doing it for them. Now, could they still flex their knee if they have a fractured patella going horizontally? Could they still actively flex their knee if they have a horizontal fracture of their patella? Okay. I would say that your guys' answers are 50-50 correct, and that the answer of no, could they versus would they or would they want to are something to think about, because the quads don't flex your knee. They extend your knee. Your hamstrings are what flex your knee. So technically speaking, they can still flex their knee with a fractured patella. It just would hurt. So they wouldn't maybe want to do it, but they still could do it if they wanted to, okay? And so we would go through all the motions and we would do our strength tests and everything else. And then we would go through and start doing our hip flexor tests. So notice there's a Kendall test and a Thomas test. Now, the difference between these, and in your book initially, I didn't really like the picture very well. So, oh, is this not the one that I wanted? Shoot a bucket. Okay, I'm going to show you. Well, actually, this is the one thing that I want to show you is in your book and in here, it shows the Kendall test, which is a rectus femoris test, having a straight leg, and it really looks like these are pretty much the exact same thing. The best way, I think, actually, to do the Kendall test is either, usually what I would do is I would have them slide all the way to the bottom. Yep, come. And so if I think that this is the side that's messed up, I would tell her to lay down. And then what we would do is take her opposite leg, and I would bring this all the way up. And then if I was having problems, I would say, okay, you can even grab it. So put your hands here and then pull it in for me. And then what I would be looking for is for this leg, if she had tightness on this leg, it would kind of come up off the air a little bit, or off the air, off the ground, because she would have so much of her quad tightness that it would kick it up, and or her leg would start extending when we did this. That is the best way to do a Kendall test. Because notice the way that these pictures are set up, it really makes it look like the Kendall test and the Thomas test are identical, but they're not. It's much better to have knee flexion, so that way you're including and you're really stretching out the rectus femoris. And so it's really almost the same position. And then the difference is, and then scoot back up. To do the Thomas test, you're just looking at the deep hip flexor, so that iliopsoas, the iliacus, and the two psoas muscles. So again, if I thought, I was trying to figure out if it was her rectus femoris or her deep hip flexors, we would do the same thing now, and she would take this leg and she would squeeze it in, and then I would look for this leg or this part of the leg to come up off the table, because those deep hip flexors would be tight. But if it's nothing, it would stay nice and flat on the ground, and she could pull that knee all the way to her chest. So that's something that I want you guys to be able to identify and know the difference, because knowing where the muscles are and what muscles are involved in doing special tests is going to be something that's important for you when you're trying to identify what the best test is for you to do. When we talk about the Faber test, also known as Patrick's test, when we do this basically is kind of putting them in the position that the sartorius goes in. So you are putting them into flexion. So notice we flex the hip, then we abduct the hip, then we externally rotate the hip. And the goal is you put your hand on one iliac crest, and then you put the hand, maybe it's better if I use the other side so that way they can actually see what I'm doing. Put the hand on their iliac crest, and then put the hand on the knee. And what you would be doing is you would be pushing down on both. So you're pushing down on their ASIS here, and basically on their MCL on the other side. And you're looking to see if they have pain on the same side. And it could be in their anterior hip, it can be in their groin, it can be in their SI joint, it can be in a lot of places, but you're looking for same side. So if she has pain on the opposite side, that's not a positive Faber's test, okay? Not a positive Faber's test, that's weird. It's if it's on the same side, that's what I'm looking for. And what you're looking for is for it to reproduce the pain that they're talking about having normally when they're not in the clinic. So don't ask, does it hurt? You need to ask, how does it feel, or what does it feel like? And if they say it feels like it feels when it's all messed up, or it's the same kind of pain, that's what you're looking for. And then when we have Gainsland's test, it's similar kind of to what we did for the Kendall test, but instead of just letting the leg hang, we're actually actively putting the hip into extension. And so we can do it off the side of the table, or often what I do is I have people come all the way to the very end, and not just their knees. Like basically I tell them to stand up and then barely put their butt on the edge of the table and then lay down. So notice their whole hip is hanging down here. And then I would say, if I think it's this side, I would say, okay, bring this up, and I want you to hug it all the way to your body. Squeeze, squeeze, squeeze in. And then, and this is really, you can also stretch people's hip flexors this way. But when I look at this, what I would do is at first, I would just push their hip down to see how far it goes. And then I would use my leg, and I would start, she's gonna cry pretty soon. Her flexibility is not good, y'all. But I would start to then flex her knee to see how far I can get it. And basically what I'm looking at here, one, it matters, am I looking at flexibility, or am I looking at, because flexibility is one thing, or am I looking at something going on like up in their SI joint or that kind of thing. So again, this does both SI joints, but what I'm looking for is the side that I'm pushing down to be the side that I'm really focusing on. But it does put stress on both of them. Okay, you don't have to be in that position, by the way, isn't very good or very helpful.
It's a good stretch though.
Yeah, it is an excellent stretch, and if you need to stretch out your hip flexors, that is, and you have a partner, I highly recommend doing it. What does it mean if it's on the opposite side? They're fine or something else. Axel, I would say the general answer to that question would be that I'm trying to think if I've ever had anybody that's had pain on the opposite side when I've done that. I don't know that I've ever had people have pain on the opposite side, to be honest. And I would have to do a really thorough eval to figure out what I thought it probably was if they're having pain on the opposite SI joint. My guess would probably be that they have some kind of torsion of their sacrum. It could be like a anterior posterior rotational torsion that's causing those problems. So I'd actually really want to focus in on their SI joint on the posterior side and see if it was a mobility issue. But good question. Tensor fascia latte. A lot of the kids that I've taught before think about it like a coffee drink as a latte drink. But it's your IT band test, and there's lots of different tests that we can do for that. So there's Renee's, Noble's, and Ober's. Renee's is really easy. You just have them stand up. And again, you're looking on the side that they're complaining of pain. And so let's scoot that way because I think the table's in the way. So what you would do is you would say, okay, I just want you to stand on one leg, and then basically tell them to do a single leg squat. And as they go down, if doing that reproduces their symptoms around 30 or 40 degrees of knee flexion and they feel like a snapping or pain that would be happening kind of right out here along the side of their leg, that is what the positive test would be. For Noble's test, you would have them lay on their back, and then they would actively bring their leg up. And you can do it from knee flexion to knee extension. So they can even start there. And then as they slowly start themselves bringing their leg up again, they would feel that snapping around 30 degrees. Did you feel it? Oh my Lord.
Oh, no.
She needs to stretch. All right.
It's very tight.
And then the last one, which I'm going to have to get on this side of the table to be able to, well, actually we'll get on the front table. That'll be easier. So then the Ober's test, there's a couple ways to do it. If you guys watch the video, I'm going to face that way. It doesn't matter, face that way, yeah. So to do Ober's test, what you would do is, and then scoot all the way back because that way I can drop your leg off the table. I don't want you to fall, I promise. So there's a couple ways to do it. You can do it with their leg straight, so their knee in extension, or with their knee in flexion. One of the ways to prevent them from rotating a lot and also to make them feel more comfortable that they're not going to fall off the table is tell them to take their bottom knee and flex it. So that way they kind of bring it up a little bit. So that way they have a little bit more leverage. So that way they don't feel like they're going to roll and they have a little bit of anterior motion. But this is a passive test. So you would hold their hip, relax for me though. And we can bring it all the way up and keep them from rotating and then bring their hip back. Oh, this is going to be bad. Relax, relax. And then, oh, it kind of goes, except for your legs rotating. Relax. And her leg should drop more, ideally, than what it is. But then the other way to do it is bring them into neutral and then flex their knee. See, this is how I know you're not relaxed, because you can't even flex your knee. Relax. And then you would bring them up into abduction and extension. Woo! And then see if it drops, and her leg doesn't drop basically at all. Notice when I let go, her leg stayed right there. And then it popped as her AT band shifted over her femoral condyle. So, or her greater trochanter, I mean. So there's two ways to do Ober's test, and those all really look at the IT band, which can cause problems at the hip as well as down at the knee. And my recommendation to Leah is that she stretch a lot and get on some foam rollers and maybe have her husband do some friction massage on her leg. All right, Trendelenburg's, we just talked about that previously, but that works for a lot of things. Oh, sorry. Can a tight AT band cause knee arthritis? It cannot. No, it can't cause, oh my leg. Yes, you're exactly right. That was bad. But no, good question, Will, and no, it can't. What it causes is just irritation in the knee and stuff, but it wouldn't actually cause arthritis or patellar tendonitis. Yeah. Piriformis test. So there's a couple ways to do this the way that they have it going on right now, and you can lay on your side again and face that way. Oh, sorry guys, we're kind of going over a little bit. So I would have them lay down, have this leg be up, and then, oh, no, actually down, sorry. Bring them up. Then I would flex, and and I would drop them. Now your piriformis isn't too bad.
Oh, good.
And so your piriformis is one of your deep six muscles, so it's way in your butt, and this is what's gonna help you kind of go through. And if they can drop their leg, then that's a good sign that at least their piriformis is good. And then onto her stomach. And when we do Eli's test, what we're looking for again is problems. So if I go and I bend her leg, it should just bend normal, because now I'm again looking at her rectus femoris to see what kind of flexibility we have. But if I do this and then her hip, like she actually flexes her hip and she comes up off the table, that's telling me that she doesn't have very good hip flexor, or actually really rectus femoris flexibility. And so that would be a sign that we really need to focus on her rectus femoris flexibility. Okay. All right. Last couple things. Roll over on your back for me. And I can remove this. Maybe other way. Okay. Leg length stuff. This is in the knee and in the hip. People get this confused all the time. And I want to point out that on your guys' PowerPoint, I don't know what happened, but they were backwards. This is the right way. The true is ASIS to medial malleolus, and the apparent or functional is umbilicus to medial malleoli. So make sure that you guys keep that straight, okay? That they were written incorrectly on your guys' PowerPoint. So I want to make sure that I point this out. People can be born with this, like you can be born with a shortened femur or a shortened tibia on one side, or you can have an injury, or so that would lead to the true thing. And the way that you would do it is, again, you would find their ASIS and measure straight from here to their medial malleolus. And then I would pick it up and I would do the same thing on this side, and I would compare the length of them. And they should be within a couple millimeters of each other. A lot of people just naturally aren't the exact same, and that's okay. To do the apparent, meaning like maybe we have some hip rotation or something, I would find her umbilicus, which is also called her belly button, and I would measure from there to her medial malleolus, and then pick it up and go here to her medial malleolus, to make sure that I think if that's off, then that's more an apparent one, or she has some kind of rotational thing going on in her hips. The one thing that we would do before we do these types of things, or any kind of measurement with the lower extremity, is called clearing the hips. Because usually when people lay down, they don't lay down evenly. So what we tell them to do is get in a hook lying position. We say, okay, now I want you to pick your hips up and then put them back down. And then I just tell them to relax as much as they can. Just nice big breath. She's terrible at this. And then I pull their legs out. So that way I can tell, like in case she laid down funny and she's kind of cockeyed, that I can make those corrections. But that's kind of how I do that. And then this is just looking at these. But again, I wanted to make sure that I pointed out that your PowerPoint said the opposite. So know that this is the correct way to do it. So anatomic, like actual bone length is different. We're measuring from the ASIS to the medial malleolus. And then the apparent, so some kind of weird pelvic rotations, my hips are wonky, is coming from my belly button down. And then this image is just kind of showing you again a little bit how that is done. Okay? And I think you guys should have those pictures, but again, I just put some extra stuff on there and you can stand up. That helps you understand that that's the stuff that we're looking at. Do you want to stop the screen sharing for me?
Yeah.
Okay, so does anybody now have any questions?